Thank you for taking time out of your busy schedule to view this presentation on evidence-based practices in children's mental health. We believe that the adoption of these core competencies into practice will improve the outcomes for children with behavioral health needs and their families. These foundational modules are developed to be viewed by family members, higher education students, paraprofessionals, and professionals. A list of resources and references have also been provided. This module will be presented by Dr. Cassie Yackley from the Dartmouth Trauma Interventions Research Center, Giselle School of Medicine, Department of Psychiatry at Dartmouth College. The New Hampshire Children's Behavioral Health Workforce Development Network is to build a sustainable infrastructure for the professional development of the children's behavioral health workforce based upon the core competencies and infused with the system of care core values and guiding principles. The need is for New Hampshire to have an adequate workforce and an infrastructure to support those who work with children, youth, and families. The New Hampshire Children's Behavioral Health Core Competencies were developed in 2011 by a representation of diverse stakeholder groups, including child-serving community mental health providers, family organizations, state policymakers, and university staff. The goal was that the competencies would be the first step in developing systematic and comprehensive human services development infrastructure. The competencies were developed using the system of care core values and principles as the foundation. There are 7 domains: family-driven and youth-guided practice, cultural and linguistic competence, childhood development and disorders, screening, assessment and referral, treatment planning, interventions and service delivery, systems knowledge and collaboration, and quality improvement. The competencies are organized for professional staff by levels of knowledge and skills in each domain. There are 3 levels: foundational, intermediary, and advanced. The levels are designed to identify the skill level of practitioners. They are fluid and not specifically tied to certain formal education and training or position titles. A copy of the report can be accessed, and a link is provided at the end of this presentation. This is one of a series of modules designed to support the development of core competencies in the children's behavioral health workforce. This module provides an overview on evidence-based practices in children's mental health, with a focus on what these interventions have to offer participants. We define terms and concepts commonly associated with evidence-based practices and dispel some misperceptions often held about evidence-based practices. This presentation describes the process by which a practice becomes evidence-based and identifies some of the potential challenges and benefits that come with using evidence-based practices. The aspects of helping relationships demonstrated to produce positive outcomes are also reviewed. A host of resources are suggested for finding an evidence-based practice trained provider, locating resources for evidence-based practices in children's services, and for New Hampshire organizations that support evidence-based practices.
Hello, and welcome to this presentation on evidence-based practice in children's mental health. First, I'd like to start with a brief overview of the presentation. This presentation opens by talking about what an evidence-based practice has to offer consumers of those approaches. There are numerous misconceptions about evidence-based practices, which discourage their use at times, and we'll discuss some of these misconceptions and the actual truth about those ideas. We will next turn our attention to the definition of an evidence-based practice, as well as a number of other concepts associated with the term. Additionally, we will explore the process of developing an evidence-based practice, describe some of the benefits and challenges of evidence-based practices, and look at the core principles of evidence-based practices for children. The remainder of the presentation will address the importance of a helping relationship and will provide local and national resources you may consult about evidence-based practices for children. What does an evidence-based practice mean for me? Why is it important to know that an approach has an evidence base? An evidence-based practice, or EBP, is an approach which has been proven to work under certain circumstances. An EBP means a person has some assurance that the interventions will work for their concerns. Just like at the doctor's office or when buying an appliance, you want to know that the service you are receiving or what you are purchasing has some guarantee of working for what you need. The activities a person is asked to do should be shown to be useful. For example, when my therapist asked me to complete a workbook to help me deal with my anxious thoughts and feelings, I deserve to know that doing that exercise is likely to help me because it has really worked to help other people like me to feel better. There are a number of terms and concepts associated with evidence-based practices. First, evidence-based practices are described as well-supported programs and practices. This means that they are able to clearly describe how change happens. They have a manual and training that explains the components of the approach and how to do it. Evidence-based treatments are similar to evidence-based practices, but refer to treatment settings in particular. Evidence-informed approaches are known as supported programs and practices. These practices also describe how change happens, have a manual, and have studies proving their effectiveness. The primary difference is that in EBPs, effectiveness has been demonstrated in multiple settings. Promising practices require only one study that supports its effectiveness. 3 additional concepts associated with EBPs. The first, empirically supported, means discovered through the empirical process, or the evidence is based in research findings, which come from the systematic collection of data through observation and experiment, and the formulation of questions and testing of hypotheses. A practice is said to have efficacy if it is shown through trials that the intervention produces the expected result under the ideal circumstances, whereas effectiveness is demonstrated when the approach is effective in real-world conditions. Most evidence-based practices take into account individual differences between people. Although it may seem at times that such approaches can be exclusive, it is important to know that the method has worked for a situation similar to yours, not a condition that is not the same. For example, I want my eczema cream to be shown to be effective on eczema, not on someone with an upset stomach. There are a number of common misconceptions about evidence-based practices. I've encountered a good degree of negativity when talking with others about EBPs, and must admit I too have been skeptical about them in the past. Many of these impressions are based on misconceptions about what an EBP might look like. First, evidence-based practices eliminate all clinical judgment. Actually, being able to deliver an evidence-based practice still depends on good clinical expertise and judgment. 2. An EBP excludes the use of all unsupported treatments. Approaches to therapy that do not have evidence to support their effectiveness can still be offered, but clients should be informed of this, as well as other approaches for their concerns that do have research support. Third, an EBP necessitates a cookie-cutter approach. As long as the main treatment goals and methods are used, they can be tailored to meet the individual needs of the client. Randomized controlled trials are considered the best kind of evidence to demonstrate an approach's effectiveness, so they will continue to be relied on heavily. However, there are other forms of research that are also acceptable. Lastly, evidence-based practices apply only to specific populations. The argument is that groups of participants in research studies are composed of individuals with certain symptom presentations or diagnoses, and that this takes into account individual difference. In addition, it's more likely for a treatment to be helpful for a client with a certain diagnosis that has been proven effective for others with a similar presentation than other treatments. Most EBPs take into account individual differences. Although it may seem that such approaches can be exclusive of some people, it's important to know that the method has worked for a situation similar to yours, not a condition that's not the same. For example, I want my eczema cream to be shown to be effective on eczema, not on someone with an upset stomach. According to the American Psychological Association, an evidence-based practice is a combination of factors that include the best available research, clinical expertise, and patient characteristics, culture, and preferences. The preferences a person has for the types of interventions they participate in is an important part of success. The knowledge and the abilities of the provider, as well as his or her use of the best research about the topic, are equally important factors. Ultimately, the purpose of an evidence-based practice is to promote effective psychological practice and to enhance public health. So how does a practice become evidence-based? A researcher and model developer prove that the approach works, and here's how. They develop an intervention or way of doing something and describe it well enough for others to learn how to do it themselves. Next, the developer tries the approach out with a certain group of people and finds a way to determine whether or not it has made a change for the person or persons who receive it. Next, if the approach is successful in getting the outcomes it's supposed to with enough people, the developer can say that it's likely to be helpful for people in similar circumstances or experiencing the same conditions. In a research setting, the efficacy of an approach is tested by delivering the intervention uniformly and exactly to a narrow and specific group of people. In mental health treatment, this usually means a manualized approach. We are relatively certain that any positive changes observed are because of the intervention we are testing. Following testing in the research or laboratory setting, an approach is then tested in the real-world environment. The effectiveness of an intervention is evaluated with a broader range of people and circumstances. Positive results that happen after the intervention may be due to the intervention or to do with other factors occurring for the person at the time. Next, they look at the results and draw conclusions about the effectiveness. Typically, those are either beneficial or established, emerging, unknown or unestablished, or ineffective or harmful or adverse. Once an approach has been studied or tested, it can be evaluated based on what kind of outcome it produced and the quality of studies about it. The evidence base for practices is provided by randomized control trials. Randomized control trials, or RCTs, are considered the gold standard for studies of efficacy. A randomized control study means that participants are randomly assigned, or participants receive the treatment or do not receive the treatment based on chance. For example, the computer selection of randomized numbers. Secondly, the intervention is applied very specifically to a particular type of people or circumstances. To make sure that all the elements of the approach are applied, it has to be described in detail and followed carefully. This is often referred to as fidelity. The outcomes also have to be measured in both the treatment and control groups. This means that everyone participating in the study are given the same surveys or tests to measure whether the approach has worked. In the end, differences between the two groups can then be said to be the result of the intervention you are testing. We've begun to talk about randomized controlled trials. So what are they? Randomized controlled trials are considered the gold standard for studies of efficacy. Participants are randomly assigned to treatment or control groups. Participants receive the treatment or do not receive the treatment based on chance, for example, the computerized selection of random numbers. Next, to make sure that all of the elements of the approach are applied, it has to be described in detail and followed carefully and exactly. This is referred to as model fidelity. The intervention is applied very specifically to a particular type of people and circumstances. Next, measurement of outcomes. Outcomes for both the treatment and control groups are carefully and precisely measured. This means that everyone participating in the study are given the same surveys or tests to measure whether the approach has worked. In the end, differences between the two groups can then be said to be the result of the intervention you are testing. While there are clear benefits to the use of an evidence-based practice, there are also risks or challenges associated with the implementation of an EBP. Benefits. First, cost effectiveness and resources. Using EBPs represents a wiser use of the available resources because it uses interventions that have been proven to work. In addition, the research behind the EBPs give the treatment more credibility for third-party payers, the community, and other key stakeholders. Second, it provides for choice for persons receiving services. Historically, patients or clients did not have much of a say in the choice of treatment and intervention. This is especially true in institutional settings, where the focus is often placed on symptom management rather than developing skills and abilities that can lead to healthier relationships. The use of EBPs then allow for increased transparency and includes the client or patient in the development of the treatment plan. And third, reductions in time, trauma, and costs of mental health recovery. Treating mental health difficulties in children and adolescents can be a time-consuming and draining process. The benefit of using EBPs for their treatment includes a focused treatment plan and a clearer picture of what and how to assess regarding the functional improvement and decrease in symptoms. It removes unnecessary and ineffective healthcare treatment. As I mentioned, there are a number of challenges associated with the implementation of evidence-based practices for providers and organizations. First, resistance to change. People and organizations are often of the opinion that their way of working or the way things have been done in the past is the best way to do things, and then are resistant to adopting new ways of working. 2. Quality and cost associated with EBPs. The development and testing of a model is expensive, but the time and resources that agencies and providers must devote to learning an EBP are extraordinary. In addition to the initial training days, most models require clinicians to participate in ongoing consultation about the model to make sure they understand it and are implementing it accurately and effectively. Third, organizational change is required. Organizations have policies, structures, and procedures that do not fit with some models and require more extensive organizational change. Next, fidelity to the model. Providers must find a balance between delivering a model exactly as specified and adapting it to fit the needs and preferences of the client. The more changes that are made to the delivery of the model, the less confidence a person can have that it will be effective in the same way. There are a number of guiding principles for evidence-based practices for children and adolescents. First, receiving quality care should not depend on where you get it. Children and adolescents should receive the best available care based on scientific knowledge and integrated with clinical expertise in the context of patient characteristics, culture, and preferences. Quality should be provided as consistently as possible with children and their caregivers across clinicians and settings. 2. Care should be provided on a continuum. Care systems should demonstrate responsiveness to youth and their families through prevention, early intervention, treatment, and continuity of care. Third, all persons should have equal access to effective care. Equal access to effective care should cut across age, gender, sexual orientation, and disability, inclusive of all racial, ethnic, and cultural groups. Lastly, an effective EBP depends on collaboration and context. Effectively implemented EBPs require a contextual base, collaborative foundation, and creative partnering among families and practitioners and researchers alike, according to the American Psychological Association. What does one need to know about finding an evidence-based practice provider? Refer to a trusty referral source, such as the resources provided in this slide set. Later in the presentation, we'll discuss local and national resources that can provide trusted information about available EBPs. Ask questions of mental health providers and other providers about their training and their approach. It's okay to ask about the approach and then to consult your resources about whether it's a good fit for you and/or your family. Know your child's rights. In New Hampshire, there is a Bill of Rights for Mental Health Consumers, produced by the Board of Mental Health Practice for the state. It talks about the right to know about the benefits and risks of the approach taken in counseling. Do your research. Take your time to explore reputable resources about EBPs before engaging in the approach. And finally, make sure that you are making progress toward your goals. Ask about how the provider measures outcomes. For example, what survey or questionnaires will you and/or your family members be completing to monitor progress? When talking about evidence-based practice, it's also important to talk about the importance of the therapeutic relationship. Decades of scientific research have documented the effectiveness of psychotherapy. And in fact, studies have shown that about 75 to 80% of patients who enter psychotherapy show benefit. And this is true across a wide range of different disorders, concerns, therapies, and people. More recently, research has focused on what factors contribute to psychotherapy's success, and the American Psychological Association developed a task force to look at what works in the therapy relationships. It has resulted in the 9 items that you see on the slide in front of you. Based on more than 20 meta-analyses, there are 9 aspects of the therapeutic relationship proven to be effective. 1. Alliance, or the relationship between two people in which they agree to work on matters together. 2. Empathy, or the ability to share in another person's feelings. 3. Goal consensus and collaboration, agreeing mutually about the goals that are set forth. 4th, positive regard and affirmation, unconditional positive regard for the person, and ultimately affirming of who they are as a person. 5, congruence and genuineness, someone who is real, true, not fake. 6, collecting client feedback, purposefully and meaningfully asking for feedback about the relationship and approach. 7, repairing alliance ruptures, acknowledging and working to repair breaches in the relationship or alliance. 8, managing countertransference, addressing relationships in the therapeutic relationship that come from earlier relationships or relationships not in the present circumstance. And finally, 9, adapting the relationship to the individual patient. It's important that we shift who we are in interpersonal relationships. There are a number of evidence-based practices for children and families in New Hampshire. Cognitive behavior therapy, or CBT, trauma-focused cognitive behavior therapy, TF-CBT, child-parent psychotherapy, CPP, dialectical behavior therapy, DBT, rehabilitation for empowerment, natural supports, education, and work, RENEW, helping the non-compliant child, or HNC. This is a partial list of children's EBPs available in New Hampshire, but not all are available in all locations. Please ask your mental health provider about the EBPs that they provide and what their preparation in the model entailed. In terms of resources for identifying EBPs in children's services, there are a couple of good resources for this purpose. First, the National Registry of Evidence-Based Programs and Practices. The website is listed there for you on the slide. Additionally, the National Child Traumatic Stress Network, or NCTSN. Again, their website is located on the slide as well. There are also a number of New Hampshire organizations that support the use of EBPs. This is a partial list as well, but include Dartmouth Psychiatric Research Center, the Dartmouth Trauma Intervention Research Center, New Hampshire Children's Behavioral Health Collaborative, New Hampshire Center for Effective Behavioral Interventions and Supports, the 10 New Hampshire Community Mental Health Centers, the National Alliance on Mental Illness, and the UNH Institute on Disability. Thank you for taking your time to listen to this presentation on evidence-based practices for children. I've listed my email address if there are further questions or ideas. Have a great day.